Thank you so much for having me. And today I'm going to speak to you about Wilms tumor. And you'll see there's some differences between the way that we practice with pediatric cancer in the United States compared to the rest of the world. So I'd like to speak to you today about developing a differential diagnosis for renal mass in children and renewing our radiologic findings that are important for how you're going to proceed with kidney masses in children. Also, I'm going to review the pathology with you briefly and discuss the presentation, management, surgical, and medical treatment. Am I speaking too fast for the translation service, or you're good? Good. So Wilms tumor, it's the most common pediatric renal tumor, and it comprises 91% of the kidney tumors that we see in our children. It's the second most common pediatric tumor, second to neuroblastoma. And the Children's Oncology Group and SIOP, which is the European Oncology Group, have really influenced their survival over the years, giving children the best chance of oncologic outcomes compared to adult counterparts. And I believe you all have UNOP, which is a similar study organization allowing for improved care of children with cancer. With these incredible collaborative efforts, we've really seen an 85% 5-year survival and 95 to 99% for low-grade or favorable histology. These are incredible numbers for children with a major cancer. Wilms tumor follows the rule of tens, which is 10% are going to be bilateral, 10% are going to have unfavorable histology, and 10% are going to have vascular invasion, which are the ones that you really want to make sure you're looking for as these complicate your surgical evaluation and procedures. So again, our differential diagnosis for renal masses in a small child, Wilms tumor, is by far and away the most common. The next are kind of the bad players, the ones that you hope the child doesn't have: clear cell sarcoma, rhabdoid tumor, and renal cell sarcoma. So these are not going to respond to traditional chemotherapy agents like DAC, which we use for Wilms tumor, and have a high rate of bone, brain metastases, and recurrences. And then you have the others, renal cell carcinoma. We see a reasonably high rate of this in children in the US because of its association with sickle cell trait. Renal neurogenic tumors, mucoblastic nephromas, and cystic nephromas, to name a few. This is a little girl who showed up to us. Amazingly, they noticed it at the pediatric well visit. It looks pretty obvious when she lays down, but it's amazing. This is during the pandemic. People were busy, parents were stressed, and this child came in with a very visible mass. So 1 in 10,000 children will develop a Wilms tumor, more common in these ethnic groups. 90% are considered to be sporadic, and 10% are associated with syndromes. And these are important to look for, and we have some protocols that we follow for high-risk patients. I don't know what the practice is in Guatemala, but currently in the United States, trisomy 18 is now considered a survivable illness. It wasn't when I trained. But Wilms tumor patients need every 3-month screening. Trisomy 18 patients need every 3-month screening for Wilms tumor. What was once thought to be an unsurvivable chromosomal abnormality. Beckwith-Wiedemann, high chance of Wilms tumor. Denzi-Drash, Li-Fraumeni, the other cancer syndromes. These children typically present with a painless mass. Mom or dad notice it in the bathtub, or the pediatrician picks it up on routine examination. They sometimes, unfortunately, can present with an acute abdomen. Oftentimes this is due to a tumor rupture, hematuria, or hypertension. The most common age is around 2.5 years of age, but the range is from 1 to 4. I've even seen it later. In fact, I had one patient that was 22. They had her come see a pediatric surgeon, and she was carrying her baby in hand, which is awkward for a pediatric surgeon. 90% are one side, and they're associated with syndromes, preterm birth included, and have a high birth weight. We start out our tumor evaluation at Joe DiMaggio Children's Hospital with abdominal imaging, most commonly a CT scan of the abdomen, although if they have any symptoms, they likely will have received an ultrasound by their pediatrician, actually. We have what we call a strike force. So with every single solid tumor in the Joe DiMaggio Hospital, we gather an oncologist, a radiologist, and a surgeon, and we have an emergency meeting where we meet and we review the physical examination findings, the laboratory findings, and the radiology films. We look through everything together, and then those three people come up with what they perceive to be the best course of action. That happens for every tumor, every child, every time. Typically, the Wilms tumor patients will receive a CT scan of the chest, abdomen, and pelvis in order to evaluate the mass, the lymph nodes, and also the contralateral kidney. If we cannot assess whether there's a thrombus in the vena cava adequately because of the large size of the mass, we then proceed with a Doppler ultrasound to make sure that we have a clear view of the vena cava prior to proceeding with surgery. Should the child have symptoms such as seizures, headaches, or if they've already had a biopsy done at an outside institution and we know it's a bad type of cancer like rhabdoid, we obtain imaging of the brain. Here's where there's a big difference. So in the United States, Canada, Mexico, Switzerland, France, a couple other countries that I can't remember, we use the Children's Oncology Group, or COG. In Europe, and 5 countries in Africa, they use SIOP. They are actually quite similar, but with some meaningful differences. And in the end, the outcome is incredibly similar between the two. It would be great, I personally think, if we could all divide one system that works for everyone. But currently, we have 2 different approaches, and you'll hear the difference in what I tell you compared to our last speaker. So because we use COG, which started out as NITWITS and was transferred to COG later, so NITWITS was the National Wilms Tumor Database, we do our staging pre-treatment compared to SIOP that does the staging intraoperatively. So pre-treatment, we look at the tumor, whether it's completely contained, whether it's extending outside the capsule, whether there's been tumor rupture or biopsy, whether they're distant metastases, and if the tumor is bilateral. Bilateral is a stage 5, but we then stage each side independently and give each side a number, and the treatment is based on that. SIOP is an intraoperative treatment, and the staging is quite similar, except for it's done at the time of surgery, which, as you'll see shortly, oftentimes is after chemotherapy has been given or neoadjuvant therapy has been given. So with the Children's Oncology Group, we are always going to go for nephrectomy first if possible. So we only biopsy if we deem it to be unresectable, or if it's bilateral, or if there are other extenuating circumstances that I'll get into. And that's because with COG, once you do a biopsy, the child is now stage 3, and they're going to need radiation. And radiation in a small child, second malignancy syndromes, radiation to the spine, scoliosis, growth defects. So we try not to take this step if possible. So here are some exceptions: bilateral Wilms tumor, tumor in a horseshoe kidney. I learned today the word herradura is not a tequila, is horseshoe. I did not know. Intravascular extension beyond the hepatic vena cava. So if you have tumor thrombus in the vena cava up to the liver, we still proceed with surgery up front. But once it's into or above the liver, then we proceed with adjuvant therapy. And if there's involvement of other organs or extensive disease. This is that same picture I showed you of the prior baby after completion of the surgery. You can see she's completely deflated. And this is just an interesting case presentation I wanted to share with you that goes to the difficulties in taking care of some of these children. This is a 2-year-old child who presented to us at Joe DiMaggio Children's Hospital right at the beginning of the pandemic. Actually, in late March of 2020, right when everyone in the United States was running from the hospital as quickly as possible, and the mom had noticed the mass during the bath. He had a normal activity level, was running around like crazy with his 4 brothers, poor parents. He had a CT chest, abdomen, and pelvis, and it showed this on the CT component of the chest, significant pulmonary metastases. Our strike force met, but we determined that this tumor was actually resectable. It does cross the midline a little bit, but the vascular structures were visible. There's no tumor thrombus. So the strike force determination was actually to proceed with nephrectomy, portacath placement, and begin chemotherapy for treatment of the distant metastases after. However, when I went to proceed with the nephrectomy, the patient couldn't tolerate general anesthesia because of the extensive metastases and had respiratory distress immediately upon induction of anesthesia. So I quickly did a biopsy of the kidney, put in the portacath, and we took the baby to the ICU. So this patient completed his 6 weeks of adjuvant therapy after the biopsy. He did have unfavorable histology with high-grade anaplasia. After completion of the therapy, we had significant tumor reduction and proceeded with radical nephrectomy. The lung metastases regressed, but he formed a large emphysematous lesion in the right upper lobe, which he had several spontaneous pneumothoraces from, and had persistent lung disease on imaging. So this is an unusual thing with Wilms disease. Typically, the lung lesions will just melt away with chemotherapy, and rarely do you have to address these. In this case, after completion of all chemotherapy, he continued to have lung disease as well as a symptomatic bleb. So we performed with thoracoscopy, with resection of this bleb, as well as resection of the pleural metastases and some intraparenchymal metastases. All of the tumor was found to be non-viable tumor with just post-treatment effect and just residual scarring. We were able to do this actually easily thoracoscopically. We simply did a left main stem and had great access to the whole right lung. He has lesions on the left. We did not proceed with a left-sided exploration as the tumor was non-viable on all lesions on the right. So this, I want to point out some of the important differences between Nitwitzer-Cog and SIOP, because I think that they really are significant for you all to know. And correct me if I'm wrong, but I think Guatemala lies somewhere in between with UNOP. You all lean towards the SIOP treatment. So I think this could be an interesting discussion for after. So for us, we recommend upfront resection, followed by chemotherapy, essentially always. The disadvantages to that is sometimes the tumors are very large at initial operation, and they can be extremely challenging. One of the main tenets is never to rupture the tumor. So theoretically, you have a higher risk of tumor rupture, you have a higher risk of hemorrhage, and the surgery can be quite challenging and requires an enormous incision. So it's what I call maximally invasive surgery. With SIOP, they start with preoperative chemotherapy, and the European studies have an enormous experience with laparoscopic resection of Wilms tumor, which we never do because the tumors are so burdensome at the time of operation. So disadvantage is that there's uncertainty of the pathology, and perhaps you're under-treating with your chemotherapeutic agents, but you have this advantage of being able to perform a less invasive operation, lower risk of tumor spillage, lower risk of upstaging to a stage 3, radiation, etc. And in the end, the data shows the outcomes are equal. So when you perform surgery with these children, in my opinion, the most important thing is you are there to cure cancer. The parents are not going to say, wow, that scar is big. Well, they might. But you're there to cure cancer. Make the incision you need to do that safely. And if you're doing it the American or the North American way, it's a big incision. Explore the abdominal cavity. The one thing we don't do anymore is we don't explore the contralateral kidney, and that's different from what we just heard. And that's because we have all this cross-sectional imaging and we have a good view of that contralateral kidney on that. If you don't, or you're in an emergency situation, of course we do. We do, however, despite the imaging, always check for tumor thrombus in the renal vein and the vena cava, just to ensure that nothing was missed, as those images can sometimes be misleading due to the mass effect on the cava. We mobilize the kidney and are careful to obtain vascular control, avoiding rupture truly at all costs. We resect the bladder. We do not resect the bladder. We resect the ureter as close to the bladder as possible. And we harvest nodes from the pararenal, para-aortic, and paracaval regions. If the tumor cannot be safely resected when you explore the abdomen, we just do the biopsy and come back another day. The surgical goals are safety. These children have a survival with treatment of 95 to 99%. You should not risk death in surgery. Radical nephrectomy without spillage, and it's important to sample all the lymph nodes. The number you give was 7. We use 6 to 10, and honestly, our oncology team is very angry with us if we do not give them at least 10. Document all findings. For the children's oncology group, they expect a detailed documentation of everything that we see: omental involvement, extension, peritoneal implants, any evidence of spillage. All these things are very important to the final staging and in making sure that your patient receives the right chemotherapy and not excessive chemotherapy. The chemotherapy and the radiation have secondary malignancy syndromes, additional complications, so the minimum amount necessary is what we want to give, so just the right amount. It's like Goldilocks, not too big, too small, we want just right. And of course, we obtain central venous access at that time for chemotherapy after. The lymph node sampling, again, they're quite strict with the children's oncology group, so they want a minimum of 5 nodes. As I told you, our oncologists want 10. Renal hilum, para-aortic, paracaval. This is the #1 error by surgeons in the children's oncology group of inadequate node sampling and therefore inaccurate staging. This is a huge push across children's oncology group and SIOP to ensure that all surgeons are well educated. They need the nodes. The vascular anatomy in these patients is very challenging. The tumor displacement of the vessels can be confounding at the time of surgery. As a general surgery resident, I received a patient, at the time I was a resident in Houston, I received a patient from the Rio Grande Valley who was transported in emergently after a surgeon took her to the OR for an acute abdomen and ligated the aorta. The aorta in that child was smaller than the renal artery because the renal artery was feeding this huge tumor. It can be very confounding. I have also had a patient referred to me who the SMA was ligated because, again, the surgeon was confused by the anatomy. It is very disruptive to the pattern recognition that as surgeons we have when the vessels are so distorted and so pushed out of the way. So careful dissection with clear delineation of your vascular structures is key. The bulky nodes, if present, can really impair this. There are some exceptional cases that I want to speak to you about. One is nephron-sparing surgery. So we use this in patients who have a solitary kidney, patients who have bilateral disease, patients who have the horseshoe kidney, and patients who are at high risk for metachronous tumors, so Denzi-Drash, Beckwith-Wiedemann, these sorts of things. In these cases, we perform heminephrectomies, higher rate of recurrence, bigger need for surveillance, but important to ensure preservation of renal function, as many of the chemotherapeutic agents are nephrotoxic. And then resection of the metastases, which we spoke about. Another exceptional problem that these patients can have is the tumor thrombus. The tumor thrombus typically responds to chemotherapy and will regress back relatively well. And again, if it's suprarenal, we simply obtain control of the vessels. You do need to obtain significant control of the branches draining into the vena cava because the tumor thrombus causes collateralization, and the bleeding can be significant when you open the cava. But once you have good control, opening the cava and slipping out that tumor thrombus, a periosteal elevator is the perfect tool for freeing up that tumor thrombus. When we have cases where the tumor thrombus is up to the atria or close, so the suprahepatic, and doesn't regress, we actually pair with our cardiothoracic team, and our cardiovascular team puts the patient on bypass. We go in through the abdomen, they work from the atrium, we work from the lower cava, free the tumor, pull it from whichever region it wishes to go. And we've done that once in the last year at Joe DiMaggio, and I did one of those once about 5 years ago when I was at University of Miami. But really effective in safely removing a large tumor thrombus. There are really two groups, favorable and unfavorable, although the Children's Oncology Group and SIOP keep tweaking this to some extent. But favorable is no anaplasia, well differentiated, and accounts, fortunately, for approximately 90%. Unfavorable histology, fortunately, is only approximately 10%, but these are really the bad players. They're anaplastic, they tend to have a high level of metastases, clear cell, rhabdoid. And this is the most important predictor of how your patient's going to do. Nephrogenic rests are a precursor, and we see actually approximately 35% of these in unilateral and almost all of bilateral. Our adjuvant therapy in these children is limited to patients resection only with no adjuvant therapy in a young child with a small tumor. They can have resection only, and they're done with follow-up. Obviously, they have to have favorable histology. These children have a 98% survival with surgery only. Stage 1 and 2 with favorable histology, surgical resection and chemotherapy with vincristine and ductinomycin, the standard for the children's oncology group. And then stage 1 and 2 with diffuse anaplasia, they receive radiation, doxorubicin, cyclophosphamide, and or etoposide, and it's a 6-month trial. Here you can see the additionals for stage 3 and stage 4, with stage 4 receiving whole lung radiation, which involves a lot of spine radiation and risk of scoliosis. So bilateral Wilms tumor, I think, is a very unique situation. Also horseshoe kidney as well. We typically see this in younger patients. They typically tend to be syndromic, but not necessarily. And these can be very challenging. These children get upfront chemotherapy regardless of the independent staging of the sides, and that's because the chemotherapy is nephrotoxic, and having the whole kidney in place to deal with the chemotherapy is the best way to avoid end-stage renal disease. And then they're resected and, of course, independently staged. Neonatal Wilms tumor, thank goodness, is quite rare and is almost always favorable histology. And here you can see the staging and the 5-year survival, the percentage in survivals for these children, which overall is really, was quite good. So favorable Wilms tumor has an overall survival with recurrence, has an overall survival of 50%. So it's best, I believe you mentioned earlier, first time, right operation, right place, right intervention, which is why we utilize a strike force. Your first shot is the child's best shot. Unfavorable Wilms has very poor survival rates when it recurs. End-stage renal disease is very rare with unilateral tumors, but becomes much more common with bilateral tumors. And it's important that everyone have really improved education regarding the effects of multimodal therapy, second malignancy syndromes, cardiac dysfunction, scoliosis. And the patients are followed very closely for 5 years, and then with lifetime screening. And that completes my presentation. Again, thank you so much for inviting me to come speak with you for the last 2 days. I've really had a wonderful time, and it's been a pleasure to meet you all.